Okay, Dr. Pomper, let's take you back just a few years when you were starting in medical school. How did you end up as a radiation oncologist?
Well, that's actually a long story because I really wanted to be a neurosurgeon. And I was very interested in neurology. And when I rotated through surgery, the chairman of the department was a world famous surgeon named Dr. Sabiston. And he really felt that, surgery was the best thing to do. And he really conveyed that. He would take all the students who would rotate through surgery and talk to them about surgery. But the way he approached it was, he approached it like an internist. He always really understood the pathophysiology, and he didn't jump to surgery. And you meet this man, and you just think, wow. He was just so amazing. I said, so I like neurology, I'm gonna be a neurosurgeon. So I applied for neurosurgery. And that was what I was going to do. So neurosurgery had an early match. And that meant that I was really applying already when I was at the end of my third year of medical school. And I met somebody who just happened to come to my synagogue, and he starts talking to me. He's a radiation oncologist. And I didn't even know what radiation oncology was. In those days, really almost nobody started out in radiation oncology. It was always you were doing your residency and you'd learn about it because you really didn't get much exposure, no pun intended. You don't get much exposure to radiation when you're in medical school. So I meet this guy, he's a radiation oncologist, and he's telling me, you should be a radiation oncologist. And I said, well, why? He says, first of all, surgery, the lifestyle, I'm telling you, check out radiation oncology. I said, okay, well, fine, I'll look into it. Anyway, next thing you know, I show up for my rotation that Monday, and they say, you're not here. I said, what do you mean I'm not here? I'm right here. This is where I was last week. I said, no, you've been transferred. I said, transferred? Where am I supposed to go? I said, well, you're in radiation oncology for the rest of this rotation. I said, really? So next thing you know, I'm doing radiation oncology for my elective, and I love it. It's amazing. You're really helping people who are sick, and you're working with really high-tech stuff, and you're at the cutting edge of research. And the lifestyle is, it's very easy to limit your lifestyle, and you don't have to take everything home with you unless you want to. So I see the guy again a couple weeks later, and he says, so is this it? Are you gonna be a radiation oncologist? I said, listen, I gotta tell you something. I really do like it. I think it's great. But I've sort of had my heart set on this. Let me just see how I like surgery, and I'll keep it in the back of my mind. So I did get into a neurosurgery program, thank God. And my first year of general surgery was awful. My personality in many ways is like a surgeon, but not like a surgeon. So I just didn't fit. It was a real misfit. And I wanted to wait till I actually did my neurosurgery rotation, which was not until April of the next year. So I went through most of my year of surgery. And I went to the chairman at the end of the rotation. I said, this is really, I just don't think I want to be a neurosurgeon anymore. Now he was a very nice man, and he said, what were you thinking of doing? I told him I was thinking maybe radiation oncology, and he said, actually I was thinking of that, and it's a very good specialty, and I have to tell you, there's only one slot per year in our program, and if you're not committed 110%, I don't think you should do it, because it's a grueling program, and if you left, I would be without a resident for that whole year. So anyway, I decided then to apply to radiation oncology programs, and thank God, it's been wonderful.
Now, how much would you say it's changed in your 30 plus years of practicing?
Well, it's very interesting because really in principle it hasn't changed at all. My relationship with the patients is the same. What's really changed is the physics. And when we were learning, we had to go through all the isodoses and write them out by hand, draw them and stuff, and learn how things went. And we were very active in the actual treatments. Now, everything is much more automatic. You've got these computers doing things like crazy, and we have to understand it, and we have to approve it, but we're not nearly as involved in that aspect. But we still, with the patients, it's the same as it was before.
Now, how'd you get involved with CyberKnife? How'd that come into your world?
Well, actually, when it first opened, when the first CyberKnife Center of Miami first opened, it was very exciting, and I did get training in it, and I really loved it. But I don't know, I was just so busy with my other stuff, I never did anything for a while. And then a few years ago, I think Dr. Schwade, who was the executive director at the time, he called me up and just said, maybe you're interested in coming back and doing stuff, because I'd been on staff the whole time, but I wasn't very active. And so I started doing some patients and stuff like that, and I started saying, wow, this is really cool. I mean, I still have the same relationships with my patients, but the fact that I'm able to decrease morbidity and make the treatments in a shorter period of time, it's just one step up in making their lives better. And I love it. It's great.
You're saving lives. That must be people who are even told they have weeks or months to live, you're buying them years a lot of times. That has to really have a special place in your heart, I would think, too. And you're talking about neurosurgery, which you save lives, but this is a whole different ball game.
Yeah. I mean, I do feel really good about helping people, and I have to tell you that whenever we do a lot of neurosurgery cases, so I work with neurosurgeons also. So I still get to deal with that type of thing, but for sure, these patients, I mean, they're much more communicative than a lot of the neurosurgery patients who go just for neurosurgery, and it's really a good feeling that you're able to help them.
When you also look at where radiation therapy has come from 20, 30 years ago to today, to the targeted radiation like CyberKnife, is that finally changing? I mean, I still see a lot of patients being treated with 42 treatments for prostate cancer with other types of radiation versus 5. Where are we at on all that?
It's a really good question. I mean, the scientific community is very slow to adapt new things. Even though the principles of our radiation are the exact same of standard external beam radiation therapy. The fact is everybody's very cautious about going with higher doses and fewer treatments, even if radiobiologically you can prove everything is okay. But more and more data is showing that we are equivalent or better with possibly fewer side effects than putting patients through all those extra treatments. So slowly, the radiation community is shifting towards fewer treatments. And of course, the idea of CyberKnife, which is really the ultimate in stereotactic radiosurgery, is that you're able to do it in the fewest number of treatments, but the problem is, of course, not every center has those things, and there's a lot of politics in sending patients out, even though, for instance, our center is an open center where any doctor can come. But doctors have pressure from the hospital or the facility they're at to actually do the treatments there.
So patients have to become their own advocates, really.
Really, yes.
Seek it out and insist on what they want if they do their research.
Yeah, I'm sure that if the patient brought it up with the doctor would be very open and say something. But the problem is, if you're going to the doctor, he's going to offer you what he has, especially if it is a good treatment. It is a good treatment. It's just not necessarily the easiest treatment.
I've actually seen articles now, editorials written by doctors who say we can no longer in good conscience recommend the older types of radiation versus the targeted. What's your take on that?
Well, I think that, it really takes a lot of soul searching for people to come up with that. And people are, we're only human. It's hard for people to come to grips with that unless the data is more than black and white, because to me it's very clear that the stereotactic focused radiation therapy has a much larger place than it is currently occupying.
And more than 20 years of research behind it.
That's correct. That's correct.
30, almost 40.
Yeah.